Very thin-walled alveolar capillaries lined with capillary endothelial cells form a dense network in the alveolar walls. This gives a large surface area that facilitates rapid gaseous exchange between the pulmonary circulation and the alveoli. Each capillary endothelial cell has a thickness of only 0.1 micrometers, except in its nuclear region, where it is wider to accommodate the nucleus. The cells abut loosely against each other, and the junctions between cells are about 5 nanometers wide. These junctions permit the passage of large molecules, and macrophages can also pass easily through them. This is unlike the walls of most systematic capillaries, which do not allow migration of large molecules or cells. Type 1 alveolar cells. The epithelial lining of alveoli consists mainly of type 1 alveolar cells, also known as type 1 pneumocytes. These are large, flat, squamous cells with few organelles and thin cytoplasm. They cover about 93% of alveolar surface area. Their primary purpose is air-blood gas exchange. The junctions between these cells are narrow at 1 nanometer. This tightness is necessary for preventing the escape of fluid into the alveoli. Flooding the alveoli, alveolar edema, with fluid would prevent effective gaseous exchange by increasing the diffusion distance for gases. Type 2 alveolar cells. Type 2 alveolar cells, type 2 pneumocytes, are domed cuboidal cells in the alveolar epithelium containing a lamellar bodies that secrete surfactant. They cover only approximately 5% of the alveolar surface area. Pulmonary surfactant forms a thin film covering the whole alveolar surface. The film consists of a basal layer mostly made up of protein, a surface layer of phospholipid, dipalmitoyl lecithin. Surfactant is continuously synthesized and secreted by type 2 alveolar cells. It reduces alveolar surface tension throughout the lungs in order to prevent the basically spherical alveolar from collapsing during expiration, and decrease the effort needed to expand the alveoli at the next inspiration. It increases pulmonary compliance. Macrophages. Alveoli also contain macrophages, which enter the alveolar lumen to phagocytose dust particles and bacteria. Macrophages are part of the pulmonary defense mechanism. Collateral ventilation. As well as the main air pathways from the trachea through the bronchi and into the alveoli, other pathways link the different regions of the lungs and allow collateral ventilation. The pathways include the pores of Kohn and accessory broncho-alveolar communications. These allow communication between adjacent alveoli, which equalizes pressures and provides collateral ventilation. When small airways are blocked, these alternative pathways provide a means for maximizing the use of all available alveoli. The outer surface of the lungs is covered by a membrane called the visceral pleura. This is separated by a thin fluid film from the parietal pleura, which covers the thoracic walls and upper surface of the diaphragm. The pleural layers can only be separated by considerable force, but can slide easily over each other, like two wet microscope slides. The space between the two layers is called the pleural cavity, and contains a few millimeters of fluid that acts as a lubricant. Pleurisy and other pleural conditions. Pleurisy is an inflammation of the pleura, which gives rise to a sharp pain on inspiration. The inflammation and roughing of the pleura may be associated with a pleural rub, a creaking sound at the lung bases, best heard posteriorly. The pain and rub disappear when the pleura become separated by fluid. Pleural effusion occurs when fluid fills the space between the visceral and parietal pleura. It is more common at the lung bases, i.e. is dependent on posture. The chest wall over the effusion is dull to percussion, sometimes stony dull. Breath sounds at the site of effusion are reduced or absent, and if heard are vesicular. Emphysema is a collection of pus and occurs when a pleural effusion becomes infected. A pneumothorax is the entrance of air into the pleural space, which then prevents the lung from expanding. With a large pneumothorax, the trachea and mediastinum may be deviated contralaterally. The side of the chest containing the pneumothorax is resonant to percussion. Breath sounds are reduced or absent. Pulmonary lymphatics. The channels providing lymphatic drainage in the lungs lie in the interstitial spaces between the alveolar cells and the endothelial cells of the alveolar capillaries. These lymphatic channels drain into a network of lymph nodes that follow the tracheobronchial tree towards the hilum. In the normal healthy state, pulmonary lymphatic drainage is highly efficient. The alveolar surface are continually moistened by a net filtration of fluid. Any excess fluid is removed by the lymphatics. Under normal physiological conditions, these channels can hold up to 500 milliliters of fluid. Fluid will leak into the interstitial spaces, giving rise to pulmonary edema. If excessive fluid filtration beyond the capacity of the pulmonary lymphatic channels occurs, when pulmonary edema is present, the pulmonary lymphatic channels become engorged, as do their hilar lymph glands. This will appear as a butterfly shadow on a chest radiograph. As the left heart pressure increases, thickening of the interlobular septa may be visible, as linear shadows on a chest X-ray, known as curly B lines. These are more easily seen at the claustrophrenic angles, but may disappear as the hydrostatic pressure increases further, leading to alveolar edema. Pulmonary edema. The alveoli are the primary units for gaseous exchange in the lungs. They therefore have to be kept relatively dry in order to facilitate rapid and efficient gas exchange. The normal balance between capillary hydrostatic pressure and interstitial hydrostatic pressure, and capillary oncotic pressure with interstitial oncotic pressure, has the overall effect of maintaining a net filtration of fluid to continually moisten the alveolar surface. Excessive accumulation of fluid in the pulmonary interstitial spaces, interstitial edema, or alveolar flooding, leads to pulmonary edema. Pulmonary edema may be produced by excess filtration from the pulmonary capillaries, or normal filtration with impaired drainage of fluid. Increased capillary hydrostatic pressure, decreased oncotic pressure across the capillary membrane, and increased capillary permeability to both fluid and protein, and impaired lymphatic drainage are all things that happen by excess filtration from the pulmonary capillaries or normal filtration with improved drainage of fluid, which has caused a pulmonary edema, and the pulmonary edema leads to the increased capillary hydrostatic pressure, decreased oncotic pressure across the capillary membrane, increased capillary permeability to both fluid and protein, and impaired lymphatic drainage. In the blood surrounding the alveoli, the oncotic pressure of the plasma proteins normally exceeds the hydrostatic capillary blood pressure in the pulmonary circulation. However, there is a high protein concentration in the lungs, about 70% that of the plasma, which gives an oncotic pressure in the lungs of about 18 mmHg. Thus, in conditions such as heart failure, where there is even a small rise in left atrial pressures to 20 mmHg or above, there is an increase in pulmonary venous pressure, so net filtration exceeds the capabilities of the lymphatic drainage, and consequently pulmonary edema occurs. Alveolar edema occurs when the pulmonary venous pressure exceeds 30 mmHg.